Welcome, everyone. You are on air with RefleXion. I'm your host, Len Lyons. I have the honor to speak with Susan Thompson of RefleXion today. Susan, how are you?
Great, Lynn. How are you doing?
I'm doing great. It's coming up to the weekend, Susan, so all good. Susan, I love this for two reasons. First of all, I get a chance to talk to you, which is always good. So thanks for that. But there is some great news that came from CMS about RefleXion. We get a chance to talk about this today. There's no script, which is fabulous. I just want to hear what's going on. I want to understand it. Tell me about the news. What happened?
Well, very exciting. On November 1st, the Centers for Medicare and Medicaid Services issued G codes for SCINTX procedures. And so for the past year, hospitals have been able to report unique codes for SCINTX procedures, but freestanding centers didn't have them. So as of January 1st of next year, that's when these codes are going to be effective. Freestanding centers will be able to do that as well. And what's also really exciting is that CMS took there's two codes for SCINTX. There's a pre-treatment code called functional modeling, and that's where there's some data that's collected that's later used to create a treatment plan, and then that links to the delivery. And then there's a delivery code. CMS split the functional modeling code into two. And so what that means is that there's now an ability for us to go out and get some additional reimbursement for radiation oncologists, the professional component, as well as some additional technical reimbursement for freestanding centers.
Amazing. Congratulations.
Thank you.
Super news. That's fantastic. Was there anything else in there, or was that it? Was there any other things came from CMS about this codes?
There was also some great news about radiopharmaceuticals. And so
All right.
CMS changed a long-standing policy, a policy they've had in place since 2008, which packaged radiopharmaceuticals with a diagnostic scan. And they realized that innovation has happened in the last 15 years or so, and that they needed to keep pace with that innovation. And so they changed their policy. And so now, for any radiopharmaceutical or tracer that costs more than $630 a day, they're going to pay separately for that in the hospital outpatient department. And so we're really excited about what that means for our future research and development, and the tracers that we're looking at for use with SCINTX as well.
That's great because lots of the talk, Susan, right now is around radio tracers, right? And specifically targeted radiation therapy. And I know RefleXion, right? We're at the center of that, which is exciting. But there's lots of radio tracers that are unique and amazing, that will hopefully be used at some point and approved, cleared for RefleXion, like FAP tracers, PSMA tracers, etc. Right? But they're expensive, and how are these tracers reimbursed right now? I mean, will they be taken out of this code that RefleXion got, or how will they be reimbursed?
So we're really pleased that we've got such great news in the final rule on two fronts, or three fronts actually. But the fact that we got G codes for freestanding means that the procedures can now be reimbursed in freestanding, where radiopharmaceuticals or the tracers have always been paid separately. In the hospital department, we had the codes for the procedures, but we didn't have the separate payment for the radiopharmaceuticals. And now with this decision, particularly these more innovative radio tracers that will be working to get approved for use with our system, like PSMA and FAP, will get separate payment. So now it's the two most common sites of service where in freestanding, over 40% of Medicare beneficiaries are treated, or patients are treated, and hospitals as well will have the complete picture.
That's amazing. I mean, it's almost encouraging, or at least not discouraging, providers from using these tracers. I know RefleXion is approved right now for FDG, but in the future that could be really exciting.
Mm-hmm.
Great news. I'm glad they did that because that's a huge part of it, right?
Yeah.
Okay, everyone's going to ask this. You got these codes. They sound great. By the way, Susan, when was this? Is this something that happens all the time? Are these codes given out a lot? Or in radiation therapy, is this something really new? Like, when was the last time this happened?
Yeah, so this is not a common thing at all. And I think that's a testament to how innovative our technology is. I mean, we received a breakthrough device designation from the FDA. And then we were cleared through the de novo pathway, which essentially means that it's not through a predicate device pathway, which essentially says you're pretty much like what other technologies are like there. They realized that this was truly something new with different workflows and different patient populations. And so we believe that this is just going to increase patients' access, particularly those with metastatic cancer, where our system can efficiently treat those things.
Amazing. Okay, so the question I was going to ask you, Susan. So you got the codes, amazing work.
Yeah.
Congratulations again. Sounds like this doesn't happen obviously that often. Super. Everyone's going to ask how much are these paid? And I think when that question is asked, it's always in relation to what they're getting paid today.
Mhm.
So if you took, for an example, like a 5-fraction SBRT treatment today, how does that compare to what a SCINTX treatment would be reimbursed for a similar course of treatment, so a fry fraction?
Yeah, so SBRT is probably the next closest comparator for our technology, and our payment is double SBRT in the hospital outpatient department. I think you asked earlier, like, is this how common is this? The last time that CMS created G codes, which is what we just got, was 20 years ago. So really, really exciting to be able to get this for this technology, and again, what that means for cancer patients. For freestanding centers, we feel that we made some really compelling arguments, and the data that we use to get the payment rates in the hospital will be compelling for freestanding centers as well. And we're about to start working with Medicare contractors to price them.
Fantastic. You mentioned a modifier earlier on, Susan. In transparency, right? I had a meeting during the week with my guys, and we talked a lot about these codes, and we talked about the modifier, and I kind of half knew but didn't know. And I guess I'm just curious: is this modifier sort of considered a little bit of a bonus for as a professional code? How does that play in?
Yeah, so we're really grateful that CMS has these pathways for innovative technologies because they recognize that early adopters take on a burden of sort of the adoption curve. And so this modifier now allows us to not only get reimbursement for the technical components in freestanding centers, but it allows us to seek some additional reimbursement for the radiation oncologists in both the freestanding center and the hospital outpatient department.
Excellent. I mean, nobody's going to say no to that. So that's fantastic. So tell me, all brilliant news, by the way. Tell me what's next. Are you done? Is everything done and dusted, or is there more work to be done? What's next for Susan Thompson and RefleXion?
Oh, well, we're really excited about the conversations that we're going to start having with the Medicare contractors. Again, because I think this is really an exciting technology. And the fact that, 40% of cancer is delivered in that site of care just means that patients can receive this technology and this treatment closer to where they live. So we're going to start those conversations in earnest here right away.
All right, fantastic. I mean, from listening to you, it just sounds like the system is working really well, right? And there's a product out there that delivers a unique uh, option for patients. It might be some different sort of workflows, but it's reimbursed accordingly. And I think that's just a win-win for providers. Sounds like it's a win-win for patients as well. Um, Tell me more. Is that do I have that right?
Yeah, I think what's so great about our technology is that it's an efficient way to treat cancer patients. If you have multiple tumors, one in the lung, you've got one maybe in the femur, somewhere else, the patient can come and they can be treated in 5 or fewer treatment sessions, and they're done. Versus,
Yeah.
the existing technologies, they're gonna plan and treat generally one tumor at a time over the course of many days, often weeks. And so I'm just really excited about, if you've got metastatic cancer, you want to spend a lot more time with your family than you do going back and forth to cancer treatment center. And I think, again, with this news with freestanding, many patients are going to be able to access that much closer to where they live.
Yeah, no doubt, no doubt. Susan, amazing. I think just fabulous for the world, fabulous for patients, and a credit to you and RefleXion. Thank you for being on air with me today. It was great chatting with you. I think next I get to interview and speak with Dr. Sean Shervani of RefleXion, and he's always an interesting interview. So I'm looking forward to that. But fantastic, Susan. Thank you so much for being on air. Any last words from you that you want to relay to the audience?
Well, it was great to be with you too, Lynn. And I would say on this Friday afternoon with this great news, I'm just looking forward to just where we go from here. And I think, again, it just comes back to the cancer patients and what that means for them and their families.
Yeah, absolutely. Absolutely. That's why we're all here. Thank you, everyone who joined us today and give us your time. We thoroughly enjoyed it. Susan, again, thank you very much for being on air, and we look forward to the next episode.
Thank you.